Okay, welcome everybody that has joined us this evening, and thank you for joining the South West London and Surrey Training and Development webinar. I'll be handing over to Professor Duncan Tennent, who can introduce himself and talk about the frozen shoulder. Thank you.
Thank you. So, good evening. Those these terrible things, but I've got no idea who's there. But welcome. Thank you for giving up your valuable time. My name is Duncan Tennent. I am a shoulder surgeon from St George's and Swelliok, and I thought I'd talk a little bit this evening about frozen shoulder and impingement or painful arc, because they often get muddled and people get a little bit confused about what they do, and it does the patients a slight disservice. So if I do this, and we'll just have to find, hang on a second, get that, bring that up. And bear with me, everyone, while it's the usual thing of trying to get the technology to do what you want it to do. And there, that should, there, be with you in a second, talk amongst yourselves. Keynote, there we go. So hopefully everybody can see.
Yeah.
So the question then, is it frozen shoulder? So we're going to look at these two things and we'll run them sort of side by side and see if we can work our way through it. So just go right back to the pathology bit. With the rotator cuff, that we're talking about the supraspinatus, and with impingement, you get this contact between the top of the rotator cuff and the underside of the acromion. And that gives you bursal inflammation, and you get that pain, that classic. So you have to watch me on the corner of the screen because there's lots of movements here. That classic painful arc as they work through the mid-range. And it's mostly related to movement. No real pain at rest. And rarely it's anatomical. We hear about sort of hooked acromions and things, but they're pretty rare. Frozen shoulder, on the other hand, is inflammation of the joint capsules. This is the glenohumeral joint with progressive contraction. It shrinks itself down. And we don't really know why it happens. It just does. And we know it's got some associations with things like diabetes, being hypothyroid, or trauma, but 95% idiopathic. We've got no real clue. So they present, or they can present very similarly, but there are some fundamental differences. So with impingement, you get this lateral arm pain. They come in rubbing the arm going, I've got arm pain. And they describe this pain when taking off a jacket, classically doing a bra, sometimes sleeping, and it's that painful arc. There's always this range in the middle. When I go above it, I'm okay. Below it, I'm okay. But there's that bit in the middle. Frozen shoulder, on the other hand, tends to be a slightly more vague pain. They say it's shoulder pain. It may present like lateral pain, but it tends to be more global. And as it progresses, the range changes in all planes. So in flexion, in abduction, and in rotation, it reduces. And typically, the pain that they start with goes away after about 4 to 6 months. And they come to you saying, well, it doesn't really hurt, it just doesn't move. So they are, in theory, different presentations, but we'll talk more about that in a minute. So the natural history, as we said, with frozen shoulder, it's this gradual onset of global pain. They shrink over 6 months, and then they're just stiff. And then it gets better over about 18 to 24 months. So it runs this 2-year cycle. It's very, very odd. We don't really understand it. Whereas impingement, again, it's a gradual onset. It's often there is a trigger. So they've done the garden, they've taken up tennis again. Something has tilted slightly. And they know that if they rest, it gets more comfortable, but it tends to go back again as they return to the activity unless we break that cycle. But they don't complain usually of stiffness. So you've got this patient, and the good thing is that first line, you don't have to do lots of investigations. If you are going to do an investigation, an X-ray. It just rules out arthritis, particularly in frozen shoulder, because the main differential for a stiff, painful shoulder is arthritis. And we all look a little silly if we treat somebody for 6 months and then discover it's arthritic. Typically, if you want to investigate impingement or cuff pain, an ultrasound. It will tell you if there's any inflammation, bursal tissue, bursitis, or a cuff tear. Frozen shoulder very rarely needs investigation. If it does, if it's really odd picture, an MRI. But in my practice, I'd probably order 2, 3 a year. So pretty rare that it needs to be done. And then you get to the treatment. So when you look at impingement, there are self-exercises, and all the guidelines say that if somebody turns up with impingement, you send them off to do their own exercises for 6 weeks. And the British Elbow and Shoulder Society have agreed with Royal College of GPs, Royal College of Surgeons, and various other bodies that this is what you do. And if you haven't got the program, it's available on the British Elbow Shoulder Society website, and you can just give it to the patient, off they go. You may want to try physiotherapy, and then you may want to consider a steroid injection, and then ultimately secondary referral. Frozen shoulder, in the early phase, probably nothing until it's really declared itself. Physiotherapy has a very limited role. Physiotherapy is not going to fix a frozen shoulder. It might slow the progress down a bit, but it doesn't usually make a lot of difference. The mainstay of treatment is this thing called a hydrodilatation, which is an ultrasound-guided injection into the glenohumeral joint of a bit of steroid, bit of local anesthetic, bit of saline. And quite how it works, we don't know. But the idea is it sort of stretches that capsule a little bit. And then you get them straight into physiotherapy within about 48 hours. And it can settle it down very, very quickly. Certainly if it's an acute problem, it can go away within weeks. If that doesn't work, a manipulation under anesthetic, and then ultimately, if that doesn't work, capsular release. But again, in my practice, I probably send 2 to 3 patients a week for hydrodilatation, and I do half a dozen capsular releases a year. So the vast majority get better with hydrodilatation. So why am I bothering? These look like very different patients. So why am I waffling on about it? Well, very simply, when you look at them, the demographics are much the same. It's the same population of middle age, predominantly female, but not always, with no real history of trauma. People always try to ascribe something to it, but usually there's no significant trauma. And in the early presentation, which is what you get, I get the luxury of getting the ones that nobody else has managed to manage. So I can always look very smug and go, oh, it's obviously one of those. But in the early stage, when they come to you or the physios, you get lateral pain with impingement, but the frozen shoulder pain is very vague, and it may well look lateral. In the early phase, the frozen shoulder isn't stiff. It takes several months for it to get stiff. So they have this vague, maybe a bit lateral pain with no stiffness, which sounds very much like impingement. And late impingement, so if it's been knocking around for a while, can get stiff. That may be pain protection. It may just be that it all gets inflamed. So you can see that actually, if you get a very early frozen shoulder, you look down your algorithm, you go, it's not stiff, it's not a frozen shoulder. You treat them as impingement. And you do a bit of physio and it doesn't really work. You try an injection, and then they all of a sudden get stiff. And they come back going, well, that was a stupid idea. And I've been there. Or I've had somebody early, put the steroid injection, very smug. And they come back a few weeks later going, you've made me worse, doctor. So they can overlap, and it can get quite tricky. And there's certainly no blame. We don't blame, but there is nothing wrong with getting it the diagnosis wrong in the early stage. The problem is if you don't correct your mistakes or correct the change in presentation. So roughly, this is a very crude algorithm. What do? When they turn up, first question you ask is the shoulder stiff? Because if it's stiff, then you should really be heading down the route of, is this a frozen shoulder? So the first thing you do is get an X-ray. And if it hasn't got any arthritis, hydrodilatation. Now, the pathways for hydrodilatation can be a little tricky. We have been, George is a bit protective over them because we were getting swamped by referrals. And we had to sort of be the gatekeepers of it, but we can get them through relatively quickly. If it's not stiff, then you're reasonable to assume that this is probably rotator cuff related, it's impingement. So usual analgesia and a self-exercise program, and then have another look. If they're a little bit better, you can go round again. The guidelines say if they make some improvement, go round again. If they haven't improved, then legitimately you can send them on to secondary care. And that'll probably be through a physio referral system, but they need somebody else to have a look because they're clearly not behaving. And then at your 6-week assessment, have a look. Are they now stiff? Has the diagnosis changed? If it has, across they go onto the frozen shoulder pathway. So that's impingement versus frozen shoulder in a nutshell. It's very brief, it's very simple. I think the thing to be aware of is that although they are very different pathologies, they have overlaps that can get confusing. And what is very, very odd, those of us who are very nerdy about these things, with COVID, I typically in my practice was seeing about 1 frozen shoulder a week and probably 4 or 5 rotator cuff things. It was a rough relationship. COVID struck and I was seeing between 5 and 10 frozen shoulders a week. And the published literature now is that it went up 5-fold during COVID, and we don't know why. It's not related to having COVID, having vaccinations, anything. And it's not just a UK thing, it's the same in Ireland and in the States. And it's going down now, but you will see more frozen shoulder than you would expect. And you start to get a bit nervous that you're overdiagnosing. The other thing is that, although I told you about this range, this sort of, our typical middle-aged woman patient, we were seeing all comers. I was seeing 20-year-old men and 75-year-old men with frozen shoulder. Now, typically, if you send me somebody who's 75 with a frozen shoulder, I'll assume it's arthritis until proven otherwise. But we were seeing, and I am still seeing, people who I expect would be in the arthritis camp with frozen shoulders. And interestingly, they're the ones we often go and get the MRIs on because they just don't make any sense. So you may see people at the moment who don't fit into our little pigeonholes. And it's right to be suspicious, but don't write them off completely. So that is a gallop through the difference between the two, because they're very, very common. And it's trying to make it simple so that when you're rushed, you've got a plan, you're not worrying about it, and you don't have patients bouncing around getting the wrong treatments. So just think a little bit about the two diagnoses. Accept that you'll get it wrong because you're getting it at the cutting edge. You're the people who you get them acutely. You have no choice. You have to plump for one of these, and you're going to be wrong. Right? I'm very rarely wrong because they've declared themselves by the time they get to me, so it's easy. But you're going to get it wrong a reasonable proportion of the time because you can't get it right. So that's a gallop through. I will stop the share, he says. If I can get my mouse to work. There we go. Stop the share. And we'll happily take questions.
So we have a couple of questions already in the chat. Can you see those? I
can see those. Okay. So waiting time for hydrodilatation, once we get to them at George's, we usually get it done within about 3 or 4 weeks. The problem often is getting them into the system because they float around outside the hospital and then they appear. So often from the presentation to injection can be, 8 months or more. And that leads into the second question, which is what is the recurrence rate post-hydrodilatation? The published literature says that it's successful 85% of the time. So that's the overall, and certainly my private practice, where people come very early, I'm reckoning it's about 85 to 90%. Unfortunately, with the NHS practice, the later they come, the worse the results. So I think I'm down to about 50%. So most of my capsular releases and my manipulations are NHS patients. But so you can predict, if you get them early, you can pretty well guarantee it's going to be over. And somebody's asked, with COVID, some patients report it came on post-vaccine. Have I seen this? Yes, this is, it's a tricky one. As I was saying before, patients want to ascribe their problem to something, and they'll often say it's related to a vaccine. But often when you look at the timeline, it's possibly not. There is a condition which you may have come across called SIRVA, S-I-R-V-A, which is severe inflammatory response to vaccination, and I forgot what the A stands for, which is quite rare. Nobody quite knows why it happens, but you get an acute inflammation and then a frozen shoulder. We used to see it rarely. I possibly saw one case a year. Obviously, everybody's getting double the number of injections this year. So we are seeing more of this potentially SIRVA. There's no really good way of making the diagnosis, but it is just a recognized thing that happens, and you get a frozen shoulder as part of the whole inflammatory condition. To be honest, you treat it the same way. Treat it like a frozen shoulder, go with the hydrodilatation if they're stiff, and hopefully it goes away. Somebody's asked, when would you decide on injections for rotator cuff pain? To be honest, if the basic treatment, so self-exercises, physiotherapy, if that doesn't work, I'm very happy to go down the route of an ultrasound-guided injection. People worry about rotator cuff tears. And can I inject the shoulder with a rotator cuff tear? The answer is yes, you can. You can give one injection. It's not going to do any damage. So if you've got an ultrasound and it says partial thickness tear, that really doesn't mean anything. We don't worry about those. So you can happily inject those. If it is a full thickness tear in an older patient, so 65, it may well be a normal variant because 60% of people over 60 have a torn rotator cuff. So it may well be they've had the rotator cuff tear for 6 months or longer, and something's triggered it and made it more inflamed. So it's quite reasonable, stick an injection in, see if you get it to calm down. The younger patient, it will probably be traumatic, at which point we should be looking at those. So if you're 45 or 50, you've had an event, you tear your tendon, there's no major harm to injecting them, but ideally they should be referred up. We want to see those ones. My thoughts on steroid injection in frozen shoulder for pain relief. Yeah, it's an interesting one, because if you do a bursal injection, so the sort of thing that we've all been taught to do, that may give them a global settling of pain, just because it has a more global effect, but won't shift the range of motion. But if you do the steroid injection into the glenohumeral joint with under a little bit of pressure, that does shift the range of motion. So if they're in lots of pain, then I think it's a very reasonable thing to do to stick some steroid in, because it is pretty miserable. Accepting that they may have to have a second steroid injection to fix the range of motion. But again, having said that, quite a lot of people, if you take their pain away, they're willing to accept the stiffness. I saw a lady just yesterday in my private clinic who had been knocking around for about 6 months, and her pain had settled. I gave her a diagnosis of a frozen shoulder, and she went, fine, it doesn't hurt anymore, I'll live with that, and went away. So in answer to the question, yes, if they're in a lot of pain and you're comfortable, we'll inject. So you might fix all their problems for them. So somebody's asked, what will the timeline be to differentiate between server and frozen shoulder post-vaccine? Our MSK service would be happy to steroid inject in painful stage, but I would be wary to send somebody with server for another injection. I personally wouldn't be worried about injecting for server. It doesn't happen. Well, it happens within a few days, but they don't really turn up for a few weeks. So we don't really have a problem with steroid in relation to COVID things after a few weeks. You want to try and treat, get rid of the pain. So you might as well inject. And I don't see a downside if it's 2 or 3 weeks after a vaccination to have a steroid injection. I don't think you can put the patient off if they're in pain. Server doesn't respond quite as well as traditional frozen shoulder to a steroid injection, but I think it's worth a go. Often though, the patients say, I don't want another injection. Look what the last one did. But you can offer it. It's a good question. Are hydrodilatations for frozen shoulder contraindicated with existing degenerative rotator cuff tears? Yes, for one very simple reason, that when you're doing the injection, you are trying to create pressure. You're trying to distend that joint. If you've got a hole in the rotator cuff, you can't distend the joint, so you can't get the pressure. So you can't do a hydrodilatation. But if you have someone with a cuff tear, then you might just want to do the steroid injection bit of it without worrying about the hydrodilatation bit. And actually, because you've got a hole, it doesn't matter where you stick the needle, it's going to end up in the joint. So there are people who could have a bursal injection because it's going to do the same thing. Best described pathway for shoulder pain, and suggestions are X-rays are better to screen calcification or OA. There is always a question whether we should X-ray all shoulders, and what's my take on it? I think this goes round and round, and you're sort of doomed if you do and doomed if you don't, really. Calcific tendinitis is a different thing to all of these others. X-ray or ultrasound, whichever's quicker. And actually an X-ray, you know, you can send them off to A&E or wherever to get an X-ray. And if they're in acute pain with calcific tendinitis, the best thing you can do is put some steroid in. And I appreciate it's very difficult at your end because you don't have the imaging. And I would hope that A&E would go, this is acute, severe shoulder pain. Let's take an X-ray. Oh, there's calcium. Let's do an injection, cure the patient. But that doesn't seem to happen. So I don't really mind whether it's an X-ray or an ultrasound. In my practice, if somebody pitches up with acute pain, which looks like calcific tendinitis, I get an X-ray because I can get one there and then. If it comes back, there's calcium, I'll inject them blind. Is there any evidence of an increased risk of dislocation post hydrodilatation? No, there isn't. And it's an interesting one because you'd have thought if you disrupt the capsule, it would make them unstable. And interestingly, when we do a capsular release for a frozen shoulder, we go 360 round the capsule and basically separate the arm from the, the humerus from the glenoid. And there's no evidence that changes your instability risk. I've never had anybody have an instability problem after doing that. But yes, logically it should. So that's a good question. Any other questions? Or I managed to confuse everybody now. That's what I like. Any more questions about frozen shoulders? I think it's having that index of suspicion, being, go down on one side of the fence or the other, and then reevaluate. If you get it wrong and it's really a frozen shoulder, welcome to my world. So if you think it's a frozen shoulder, then do send them up. And we'll get to them as quickly as we can and try and treat them.
Hi, I'm not sure if you can hear me.
I can. I'll just turn the volume up a little bit.
Mute myself. I'm struggling to type. Thanks for the talk. I think it's really good. I was just wondering on your take on versus ultrasound guided injections for impingement. Particularly given we have a 6-month ultrasound guided injections at Kingston.
Yeah, the literature all says that it makes no difference. And there's not been one single study that said that the outcomes are better with an ultrasound guided than a blind. So I don't have a problem with it. The risk you run is that you do it and you do it beautifully and it doesn't work. Then the patient just blames you and says you were rubbish and couldn't do it properly, which is fine because then we look really good because we get it done under ultrasound and sometimes it works. So in practical terms, if you're comfortable doing it, then you'll make a lot of patients very happy. And if it doesn't work, well, then we can take it further. And you're not going to do any damage if actually they've got a rotator cuff tear and you missed it because you wouldn't know about it. That's going to be fine. It's not going to be a problem.
Thank you. That's our policy. If it doesn't work, is be repeated under ultrasound.
We tend to bring them in and go, okay, well, now we need a better diagnosis. So we're going to get an ultrasound. And I tend to say, well, look, why don't we give it another go while you're having the ultrasound? And that's often what the patients want because they go, well, now I've had it done properly. And we convince them that ultrasound is a better thing to do. So there's a bit of voodoo in there, but actually all the evidence says there's no difference. So yeah, if you're happy doing it, go ahead and do it. Does diabetes change treatment outcomes? Unfortunately, yes. frozen shoulder is more common in diabetics, predominantly type 1s, and there's no doubt that the severity is related to the diabetic control. And those badly controlled ones, or the ones that have the pumps, who are brittle, it's miserable. And they're the ones where I do the hydrodilatation, but I know it's not going to work. I do a capsular release, and I tell them it's 50-50 on a capsular release. They're rubbish. They just do so badly, the severe diabetics, it's miserable. I think you've got to try, but we paint a fairly gloomy picture. Any other questions? Quite happy if you don't want to type them. Silence, that's good. Yeah, so if you want to do bursal injections, then I don't have a problem with that if you're comfortable doing them, but don't feel you have to if it's not your thing. Glenohumeral injections, they're difficult to do. I probably wouldn't have a stab at it, literally, without imaging. You're unlikely to do any damage, but they're not easy to do. But if you're not comfortable injecting. What would my reasoning be for MRI over X-ray or ultrasound? Very much depends on my question. If we're looking at rotator cuff related stuff and frozen shoulder, if it looks like a frozen shoulder, I'll get an X-ray just to rule out arthritis. If I've got an older patient with impingement or cuff pain, I want to get an X-ray because I want to see if actually they're starting to get cuff arthropathy. But most of our patients, the sort of middle-age group, I'm pretty happy with an ultrasound because I'll do an ultrasound guided injection. So that's all, it's one hit. And if they get better, great, fantastic, they go away. I use MRI if it's a very atypical frozen shoulder and I don't understand it. And I'm thinking, you're 75, you shouldn't have a frozen shoulder, or you're 25. I'm not comfortable. I'll get an MRI for those. And if I'm going to operate on a rotator cuff tear and it is bigger than can be seen comfortably on an ultrasound, and what I mean by that is, I'm just going to draw you a quick picture. Here we go, my beautiful, you probably can't see that, beautiful artwork of a shoulder. A rotator cuff tear that sits under the acromion, like that. You can see that. You can't see it on the ultrasound. So I don't know whether it's there or all the way back to the glenoid. So I have a lower threshold for MRIing to plan my surgery. And if they report massive cuff tear, then I want to know a little bit more about what's going on. But most of my cuffs get an ultrasound as first line. You know, and if you happen to have ultrasounded them and they've had an injection and they've got a cuff tear or whatever it is and they're not better, then it's fantastic for me because I can do it all in one hit and go, jolly good, you've got a cuff tear, you know, we go to operate on it. If they don't have any imaging when they turn up, it just means I then have to do the imaging and it rolls on a bit. But it's not wine, by the way, just in case you're wondering. It's squash. Any other questions? But I know it's difficult when you're seeing these people because you are running blind on a lot of them. You know, if you can, even if you know they're getting referred and you can organize an ultrasound on the way in, then that saves the patient a step with us. And certainly at George's, we will tend to send, if they've not had any treatment, be that physio injection, ultrasound, we're inclined to send them back because otherwise we're just clogged up. So a couple more questions. Apart from age, any other features of frozen shoulder that would lead you to MRI? Anything odd in the history? Anything that makes you think, could this be any malignancy going on? And certainly both of those ends, you've got to start thinking sarcomas and things like that. So if there's any mention of previous things like breast cancer, and the next question is about breast cancer. But if I've got anybody who's got a previous history of malignancy, and classically breast cancer, I get an MRI, because I really don't want to be missing something. Anybody who's got, they talk about weight loss or any of those sorts of, those red flags will get an MRI for me, but that's not common. A question about hydrodilatation for patients at risk of lymphedema following wide local excisions. As long as the frozen shoulder is not a consequence of the surgery, then we've not seen it. And I've had a number of patients who've had frozen shoulders, because I work very closely with Nupi Sharma. And obviously there's an incidence of frozen shoulder after breast cancer surgery. But they also pitch up to him, 3, 4, 5 years down the line with a genuine frozen shoulder. So I've treated quite a lot of these, and there doesn't seem to be a risk. Now, a stiff shoulder following surgery, that's a different beast and probably outside our discussion. But no, I wouldn't have a problem with doing a hydrodilatation on somebody who's post wide local excision. I think they're probably more likely to have problems through the lack of movement of the shoulder than they are from the hydrodilatation. Problem with these questions is the first ones were really straightforward, and they're now getting more and more left field as we go. Plumbing the depths of my knowledge. Shouldn't take too long. Any other questions? See, you're all thinking of the fiendish questions to ask me. Fantastic.
I think that was really helpful. Thank you so much, Mr. Tennent.
Pleasure. So it's not strictly a minefield, but it can be a bit tricky. Just keep an open mind. And so if anybody pitches up in clinic with something like calcific tendonitis, just acute, severe pain, send them to A&E, who probably will not inject them. But if you can do it, that's fantastic. If they come back to you, I'm in terrible pain, they told me I've got calcific tendonitis, inject them, they'll love you forever. So I get champagne out of my patients by doing it, and they bring me bottles of champagne. So grateful. So hopefully the numbers of frozen shoulder will go down. They are dropping, but it's very weird. It's related to COVID. We do not understand why. So hopefully that's been some help. Hasn't taken up too much of your evening. And enjoy the rest of the Swelliop teaching sessions. Have a good evening.
Yeah, thank you so much, Prof Tennent. If I can just ask everybody that attended to complete the feedback forms that will be sent out tomorrow, and then you will receive certificates for your attendance. And if you have any questions, do get in touch. I'm Lucy Morgan-Jones. Thank you.